Thank you so much for the excellent talk from three panelists. Now we are come to the question and answer live session. We will have three speakers be on the panelist, Dr. Mary Mahy, Dr. Martina Penazzato, and Dr. Dan Kuritzkes on the stage with us. And you are very welcome to type in your questions or comments in the chat box, and then we will discuss your comment and questions. May I start with the first question for Dr. Kuritzkes on the interesting topics on how we can cure the patients, especially our young infants with early therapy. In your talk, you mentioned about two categories of pediatric infection, in utero infection and intrapartum infection. What is your opinion about the reservoir profile and also the chance of cure in these two populations?
I think with in utero infection, we have the opportunity of intervening immediately after birth, as we did in the early infant treatment study, and severely limiting the reservoir. With peripartum infection, I think the issues are how quickly we diagnose those infants and then intervene. I think there's still an opportunity to limit the reservoir in that situation. It may not be as comprehensive as with in utero infection. With both sets of infants, though, antiretroviral therapy alone is clearly not sufficient to eradicate the reservoir. We'll need additional interventions, presumably some form of immune-based intervention, so that if treatment is eventually stopped and a rebound, the immune system can control that rebound or potentially even eliminate those reservoir cells.
Thank you. And the next question is for Martina. You have give an excellent status of how we deal with the double trouble for pediatric HIV and also for COVID-19. However, with the new situation, the disruption from the COVID, it forced us to think outside of the box and also be able to learn from how we respond to COVID. So what did you think about the good things or the positive way that COVID taught us for pediatric HIV programs that we could learn from, and then we can catch up with the gaps that created from the disruption from COVID-19?
Thank you, Tanya. I hope you can hear me well. I'm having some troubles with the audio, but hopefully you can hear me well. So I agree with you. There's a lot to learn from this crisis. And as I mentioned in my talk, there is a lot of solutions that countries have put in place in terms of, for example, month-to-month dispensing. This is something that has a potential to improve the quality of life of children that are stable on ART. But we've also seen how community-based services could be strengthened and could be supported with some of the digital platforms that are already available in some communities. And I think these are really two key aspects that are really important and hopefully we can take forward. I think there are a lot of other stories that are being collected on the ground right now. And I think that a key message that we need to take is that we need to try to document those stories as much as possible and be able to share them with our colleagues in various countries so that we can have the highest impact possible, not just for today and the response to this crisis, but also in the future as soon as we go back to the new normal.
Okay, thank you. And next question for Dr. Mary Mahy about the cascade that you presented. It showed that from the pediatric and adolescent treatment cascade, the first step of diagnosis is the one that is critical. For infant and children, we can still have history from HIV exposed from the mother or from the families. How about adolescent that sometimes the history is not available, or sometimes they might infected through sexual transmission? What is your advice about how to increase the first 90 on diagnosis for adolescent?
Thank you for the question. I also have a difficulty hearing, so I'll try to respond clearly. So just to say, I think it's really important that we look for closing that first 90 gap for children. And what we do know is that about 69% of children that are not on ART are older than 5. So we know we need to think of alternative ways to identify those children. I think one of the things we've seen recently is looking at index testing from family members. So that's fairly easy. But as they get older, they'll be further distance from that family. And so looking for other sort of risk factors. And as well as looking at OVC services, so where maybe a parent has died and they could potentially find children and test them through that. The other thing to think about is location, where there are very high levels of HIV prevalence. Can you go into those locations and do more testing among the adolescents? That's for children who are vertically infected. When we're talking about horizontally infected, then we have to go look through more what's happening with those children, adolescents, what are the risk factors, and how do we decide what are the risk factors that make it relevant to have an HIV test? Thank you.
And what do you think about the availability of HIV self-test that start to roll out in several countries?
That's a great question, and I'm not sure I'm the right person to be answering that, but it's an interesting one. And trying to figure out at what age do we do the cutoff to say an adolescent will understand this and grapple with it. And that age, just regardless of the country, could be very different for different kids. And so I think that's something we'll be looking at and talking about in the coming years. Thanks.
Thank you. And this question from the participants to Dr. Kuritzkes. It's about, the question is that, can you mention about how the infants on very early intensive ART may test negative on HIV antibody test, especially those with suppressed viral loads? Can you tell us if they would test positive by HIV antigen tests or other tests that we can identify them in the clinics?
No, we would not expect those babies to be antigen positive because there would be no circulating viral antigen. Just like there's no circulating HIV RNA. Some of those babies may still be positive by HIV DNA, but not reliably. That does make it a challenge to be able to establish diagnosis. You're really relying on the diagnosis made at birth, and then that information has to be reliably transmitted to providers down the road in future years. It's very much the same issue as with adults who become treated immediately after infection. They too will fail to seroconvert and may test negative. And then if they show up in another clinic, they look like they're HIV negative, and that can be false information.
Yeah, so the medical records will be very, very important to be available and linked with the patients. And the follow-up questions for Dr. Daniel is also about the rates of adverse events overall in the trial if we use broadly neutralizing antibody or other trials in early treated infants. Can you tell us about that?
Sure. The broadly neutralizing antibodies study is just underway, so we don't really have data on adverse events thus far, although we would anticipate that they should be well tolerated. In the early infant treatment study, we did have one death, not due to the intervention, but due to severe infant diarrhea. The treatment overall was well tolerated. I don't have off the top of my head the precise adverse event rates. The main issue was tolerability of boosted lopinavir, which led to a number of interruptions of treatment that explain some of those episodes of viremia. But all of the adverse events are reported in the publications that have come out. So I would refer you to those. Sorry, I don't have the information first right available.
Thank you. And the next question is for Martina. Please forecast on about COVID pandemic and also how it's going to affect us in 2021 in terms of the pediatric programs and also the stock and also the supplies for pediatric programs.
Thank you very much for that question. So I think that it's very difficult to predict exactly what is going to happen next year. But one thing I think it's fair to say is that all partners that are working together at global level with procurement agencies as well as with generic manufacturers to try to plan more reliably what is going to happen next year and make sure that there's no shortage of the supply of the drugs that are going to be needed in countries next year. So I think that it's important to acknowledge the work that is ongoing in terms of country programs order and just in the effort that many partners are putting together to gather those order and try to see if there is any challenge that can be anticipated and find solutions to really address those. So I think we shouldn't worry too much. Of course, it's important that any signal of concern is shared at global level so that the partners can respond to it quickly.
And also our follow-up question is that because of the disruption in treatment during COVID situation, do you recommend that drug-resistant tests maybe need to offer prior to commencing treatment again?
So,
oh, please don't do that.
So we don't see a need for drug-resistant testing, however, and to be able to do that quickly, potentially using point to be able to act on it. So I think there is a number of once we have these children back to the facility, and once we have an elevated viral load, as you know, it's really important that we address adherence challenges and that we explore whether that child, for example, stop treatment because of lack of the medications that were needed, and that we really address all those issues before we start and change therapy. But for now, we don't necessarily recommend HIV drug resistance testing unless we are dealing with issues with second and third line treatment, where of course management of those options would be more complex in the context of a lifelong treatment.
If I can just add, I think in general, the issue is if somebody interrupts treatment, there's less concern about resistance than if people are on and off treatment repeatedly or non-adherent. So with a stock out or with disruption from COVID, I completely agree.
And the question is also from Martina. And the question is that adolescent is a period that they start to be independent from the parents. So what is your view in terms of engaging their peers rather than families, or engaging families to support adolescents?
Well, I think we've talked a lot about the potential that peer services can have for adolescents, both for testing, treatment, and prevention. And so I feel that what's been brought up, it's absolutely important. Yes, the family is an entry point, but the peers can be a much more important one for adolescents. So I totally agree with what's being flagged, and certainly there is an understanding in many country programs that this is work that needs to be scaled up and needs to be strengthened as much as possible.
Thank you. The next question is that in Tanzania, we are currently seeing a decline trend in case identification for children living with HIV because of the transitioning to adulthood. What are your thoughts on this? Has the number of children living with HIV not yet diagnosed also lower than the estimates?
So thanks for the question. I'm not completely sure that I understand the second part of it, but I think it's a really important issue is looking at our estimates, our epidemiology understanding of how many children living with HIV are graduating, if you may, to an older age group. And as a result, because they're getting older, we don't necessarily see them in the children living with HIV anymore. We do see that estimate of children under 15 living with HIV declining because of children aging out and the lower numbers of children becoming newly infected. But I think trying to find them is tricky. And we recognize from the FIA survey and other data that you do have a number of children out there living with HIV who are not diagnosed and not on treatment. And so the effort needs to continue to find those children, and not just to sit back saying, hey, they're not coming to the clinic unless they don't exist. We need to find them, and we need to put them on treatment.
And the next question is for Dr. Kuritzkes. Can you tell a little bit more about broadly neutralizing antibody trial? Is it a single drug or is it a combination?
Sure. So we're using a combination of antibodies, VRC01, the long-acting form, and 101074. So those are two antibodies that are directed at different epitopes. VRC01 is directed to the CD4 binding site, and 101074 is a glycan-dependent antibody. As with almost everything in the pediatric HIV and cure research, particularly, we're limited by which antibodies have adequate PK data in these very young children. We actually had to do the PK studies for 101074 as a lead-in here. There is data for VRC01, but we would rather use more advanced antibodies like VRC07 that just isn't available for our study at the present time, and we'll have to keep catching up as more data become available.
And the last question is for all speakers. The question is that there is stigma against families affected by COVID infection. What can be learned from HIV programs to avoid barriers to rolling out prevention and interventions in the communities?
Maybe I can take this one to start with. Just to acknowledge that I think an effective way to deal with stigma in the HIV programs has been to really engage with the community very strongly, and to have the community to be really the one to convey important messages that would increase understanding of the disease as well as the risk attached to it. And I think increasing the level of information that people have will allow them to really understand this all much better and to really reduce stigma. We've seen this in the HIV response, and I think that these can be really powerful for the COVID response. So really the community as a key actor to deal with that stigma in the first place.
I would agree, absolutely. I think not only is education essential, but we also have to be educating people about the importance of vaccination now that it looks like vaccines are really going to become available, because the way that we're going to bring the pandemic to a close is to vaccinate, hopefully universally. And that starts with teaching people about the importance of vaccination and its effectiveness and its safety.
Yeah, just backing up the two of them, I think that's such an important piece is knowledge. If people have knowledge, there's going to be a lot less threat. And so that education, the community providing that education will make COVID much more manageable than it is currently. Thanks.
So thank you very much for all the excellent talk from the plenary sessions and also the lively discussion during Q&A. I would like to close the first session on global update, and we will continue in the next session. Thank you so much.
Thank you. It was a pleasure.
Thank you.
Thank you.